Okay. We preamble to this. When I first learned this technique, it was Scotch cast, which was fiberglass. And I do prefer it because of its rigidity. Nowadays, there's a wide variety of these. This is Delta Cast conformable, which is all that they have here. I usually use Delta Cast light because it is closest to the old Scotch cast. The more modern materials, the reason that they are more flexible is because they've introduced polypropylene into the mix of the casting bandage, partly to reduce the dust, because the dust was a problem when they were using this material, primarily for fractures, because bear in mind, I would bivalve mine just after the material has gone hard, so it'd still be fairly damp, in comparison to somebody who had one of these casts applied, had worn it for 3 weeks and then they were taking it off. So dust extraction was a problem. The whole rationale behind this type of casting for me is the similarity to the snowshoe principle, the increased area of application that we were talking about this morning. So in essence, before I apply the cast, what I would be looking at is I would normally do a prone examination so that I could check the hindfoot to forefoot alignment. I would check for deformity and also for the ulcer site. Reason being for that, what I want to do is I want to create, when the patient is sitting in a supine position in front of me, a mental image of the correction of the accommodation that I want to take in relation to the redistribution of the foot. Because essentially I want to create on the medial beam here, so that's toes 1 to 3 to there, 33%, 17 on that, and 50 on the hind foot, to get as stable a redistribution of pressure as possible. Now, the challenge lies not in a pretty foot like this, but it lies with a sharp core, it lies with one where you've got deformity and you've got bony prominences on the plantar surface. Because I would contend that what you have to do is you have to use your casting material and not the soft material to make the necessary accommodation or correction. And I'll explain that as I go on. So the first step here would be to have the wound dressed with what was the appropriate dressing for the type of wound present. As I say, this normally works best on the neuropathic, although you can use it with neuroischemic. Bearing in mind that neuropathic ulcers will always be on pressure areas, usually on the plantar surface, although they can be on the toes, but neuroischemic ulcers are usually on the periphery. So I use good quality stockinette, and I apply the stockinette above the malleoli and below the end of the toes. That's for neatness at the end in terms of the finishing off. So then move to the Papler felt. Normally I would use 7mm, I prefer 7mm. 5, which I have to use here because that's what we've got, is maybe just a bit on the thin side. 10 is very difficult to cut, and it makes it difficult to get it to fit. Now, what I'm going to do is I'm going to make a customised impression of the foot on the felt. And so I'm going to take the edge of the felt about a centimetre from the end of the longest toe. I'm going to take the felt round the foot, and I'm going to make a cut proximal, just above the malleoli. What this is going to do is it's going to give me a contour of the angle, or the ankle. So when I cut it, I'm going to cut it on a curve. Okay, and normally what I would do, it's a bit difficult with the 5 and these scissors, but I'll just chamfer, the top edge. So don't want any hard edges at the point of contact. So if I may take my, can somebody just raise the bed just a fraction, please?
No.
Just another wee bit, that's it, just so you can rest on my stomach. Yeah. So what I'm looking for is I'm looking for conformity here of the felt around the malleoli. The next stage is to create a crease and a cut so that I have a seam, if you will, that follows the calcaneum up to the talus. Now to do that, normally come down, this is one of the areas for individualistic cut, because if you have a valgus or a varus foot, or a planus type foot, you may need to accommodate the amount of material that you remove here. But normally come down about 5 centimetres from your top edge and take a small semicircular cut, like so. And on a symmetric foot it should be fairly balanced. Bear in mind if it's valgus or varus, you might need to change the inclination. Essentially, that's going to give me the seam. Now I always do the medial seam first. Left a wee bit more on there, because I've trimmed that off as it goes. You can then see that there's quite a lot of material at the front end. So I want this edge to protect to the dorsum. I'll explain when I apply the cast in just a minute why we do that. So I need to trim the front edges off as well. In general terms, this is going to be the shape of the template for most feet. Now, next thing we're going to do is we're going to apply this. So, strip the sticky back edge off. And starting at the toes, we want to make sure that there's no creases in the stockinette. That's why a good quality one. You don't want one that's too fine and too narrow. So again, what you're going to do is you're going to apply this centimetre cleared here and keeping it nice and smooth and flat. Make sure there's no wrinkles at the ankle. Take this up and round and apply it smoothly there. I always do the medial aspect first, because if you have a cavus or a definitive bone in terms of the area of the longitudinal arch, you can make sure you get it well moulded in, but you can see there that I've got everything nice and flat. And then what we're going to do is I'm just going to trim that off. And if any of you are good at making steak pies, you'll just be ace at this. So I want to have my seams as flat and neat as possible, and I want that just up and over there. So everything's as smooth as it can be. Now just bend your knee for me, please. There's one other protective strip that I put. Because I'm going to cut the cast out, I want to put extra protection across the talus in case the strap from the retaining sandal crosses there. So cut a small semicircle out of the remaining piece of felt, and like the rest of it, chamfer the edges. Just slightly more awkward on 5 millimetres, 7 metres, 7 millimetres. You definitely need to do it. What we'll then do is place that. So all the bony prominences are protected. Now, before I put, it could be Foreign Flex, it could be Salona, it's the roll type bandage that's here. The most vulnerable part on this foot now when you're applying cast is the area on the dorsal of your foot, because you have protection against heat and burning where you have the felt. So the wool here, whilst adding another layer and helping to reduce the friction and shear, also is the dorsal protector when you apply your casting material. Because these casting materials are exothermic, and you have to be careful that you don't put too much on, because if you do and your protection is insufficient, then you will burn the dorsal of the foot. So that's quite important. The next stage now is, if you bend your knee very slightly and just rest that there, is I'm going to create the padded protection for the ankle. Normally I would have the rolls that are double this thickness, but I would start off with 3 turns and then essentially work my way down the foot by coming through half of the section of bandage above, so that we are minimising the amount of ridging that is there, trying to keep the bandaging as smooth as we possibly can. Now, when it comes to the toes, you need to obviously be cognisant on the height, if you've got any claw toes or anything that's prominent there. And again, I come to this bottom edge and I put normally 3 or 4 turns. Bearing in mind, if this is a broader bandage, you get bigger coverage. And then follow up and through. And I normally use 2 of these full bandages. You okay?
Got how heavy my leg was.
Just rest it there now. So it's just slightly more awkward if you have to use the smaller bandage, but I'm getting away with it here because it's a relatively small foot. So there we go. And again, that should be as smooth as you possibly can achieve. Like that down for a wee second. Now, I'm just going to clear the workspace somewhat. As I say, under normal circumstances, I would use a slightly more dense material, but I normally use size 3 as the first application and size 4 as the second application. When you're working with this, it's not like working with plaster of Paris, it's pretty unforgiving. So you've got to be cognisant of the type of material that you're using, because those with polypropylene in them stretch a bit more. So you've got to be careful of getting the tension correct. You don't want to pull it too tight, because otherwise what will happen is that you'll impinge on the toes. If it's too slack, the patient will wobble about inside it. So part and parcel of any of these techniques is knowing and practicing with the materials that you've got so that you can get it optimised. The 3 will give you a better contouring in terms of the initial application. The other thing that's quite important when you're working with these materials is they are extremely sticky. And you should not apply them without the use of the appropriate gloves. It's also something that you have to warn the patients not to touch. Oh, I've got black. So, normally it's a kind of yellow colour. Oh, I've got black and purple, so. Now, you can see there's fair stretch on that, there's resin on this. You have to check that your bandage is viable, and you can do that before you take it out of the parcel, because if it's not used in rotation, it does go hard after a period of time. When you put it in the water, I usually use tepid water. I usually use water that's not particularly cold, because I want this to go off and harden reasonably quickly. It means that you're not hanging on to a heavy limb. Immerse it in the water at about a 45-degree angle until the bubbles disappear. And if you're going to take some of the fluid out of it, then squeeze it in the water. Different if it's plaster, you can squeeze it when you come out, but if you squeeze this when you bring it out, you'll actually gel the resin together. So when it comes to the application here, I'm going to apply it to the level of the proximal segment of the malleoli. And like my other bandage, I'm going to apply it through half of the thickness of the bandage above. I'm keeping reasonable tension on it so that it will lay itself down. I'm making sure that I'm not pulling it in tightly. The patient who has feeling should feel this moderately warm but shouldn't feel it burning. And I'm going to follow it down to the end of the toes and then come back on itself. Now, when you're laying this down, this is quite important because you only get a fairly short period of time in which to get the positioning. That's why your preparative work and knowing the range of motion of the joints and knowing the relative positions of any bony prominences on the patient is important. So, could you just bend your knee and your hip for me? What I'm going to do is I'm going to bring the foot to plantigrade. I'm using the flats of my fingers and the palms of my hand. You don't want the end of your digits in this because, as I say, it's pretty unforgiving. If you leave a finger in there, it will stay in there. So at this point, I've got the head of the talus, I've got it into the midline, I've got it plantigrade, and I've got the surface and the plantar aspect as flat as I possibly can. And I'm just going to hold that and maintain that. If you have somebody who has difficulty maintaining their leg, then it may be that you have to use a colleague to help hold it, or we have knee blocks that are there that help. Now, let this come down, don't put your foot against the work surface. So, I've set the position with the first plaster, or should I say bandage. I'm now going to consolidate it. Now this is really important because people think, oh, it's a big heavy person, I need to put 3 or 4 of these on. If you do that, you generate some serious heat. So you need to be strategic in the way that you apply the cast. One of the ways of doing that is to make a slab for the sole unit. So what you would do is you would take normally the 4 and you would lay it out, 3 or 4 strips there, like so, and then use the rest of the bandage to consolidate it. That's also how you would deal with balancing a foot that has a plantar bony prominence. Because you don't want to lay it on sideways because that creates a ridge and that will create a problem. You need to do your infill using a slab and then the rest of your bandage wrapped around so that you keep it all as smooth as you possibly can. So with it being a broader bandage, you could see how this potentially could cause challenges if you were using the broader bandage to set down your original profile. I always find a 3 and a 4 for an average size foot to be the most manageable. The one area that you should never neglect is the area between the calcaneum and the midfoot. If it's going to crack anywhere, that's usually where it cracks, so make sure that it's well established there. And that it's as wrinkle free as one can get. Okay, comfy enough?
4.
Yes. You feel it more warm in that area. So bend your knee and your hip down for me so you can see there we've obtained nice flat plantar surface. And now what we need to do is we need to relax, just let that go hard. So I'll see you in 2 weeks. most of these materials will go off in about 10-15 minutes. They are walkable within 25 minutes to half an hour. Now, particularly as I'm trying to stop the DVT. What we need to do in a minute or two when this has gone off is we'll do the bivalving. Generally cut behind the malleoli, come above the bony prominences on the lateral edge. Same again on the medial side, and I usually come up and come over the navicular and down. And then we'll take a section out round the ankle so that you've got freedom of movement there, and we EP strap the whole thing together from there. Now, the benefit of this is that for each of the layers, any friction and any shear is going to be dissipated between these layers. So this is a wound healing cast, and it's meant for protected ambulation. That's essentially the qualities of it. You can, and we sometimes do, extend it to a below knee, so we'll take it to the level of the fibular head. We can bivalve the front section as well, because it's important to be able to get in and assess the wound. So it's a customisable form of an ankle foot orthosis without it using a thermoplastic. So you might wish to cease transmission for a minute or two, because
I'm quite enjoying this.
To do is to wait until that sweatiness disappears. Otherwise, your cast saw will cut it, but it's a bit like cutting toffee before it's properly set. It just makes the job that bit more difficult. You comfy enough in there. What we'd normally do also is check that the 5 little piggies are still 5 little piggies and not 4.5, that you've not crushed them all up. And the other thing is to make sure that there's no pressure on the dorsum of the foot. The reason that we leave an extension to the stockinette, both above and below, is that when we bivalve this and trim this, we're going to expose this wool. And what we want to do before we put the EP strapping on is pull that down and pull that up so that we get a nice, neat, comfortable edge. Yeah?
So is this just another version of the Scotch cast?
Well, there is, I suppose what it comes down to, it's like Kellogg's and cornflakes, you know, it becomes generic. What I would entreat you to think about this week is you will be shown several casting techniques. It's whether or not it is a wound healing cast or whether it is a total contact cast. And Maureen from King's will probably show you a total contact cast, and that's where there is minimal padding. Certain people around the world practice it where it might be just plaster in itself. Some would maybe put a small strip on the tibia or around the malleoli, but other than that it's direct application, and they would normally do that or traditionally do that with plaster of Paris. Scotch cast is the generic name for the casting tape. Okay, and that's why you've got to be careful when you're doing the applications of these. You need to know your materials, because some of them are more dense and some of them are more elastic. From my point of view, I want this to be as rigid as it can be so that I can have protected ambulation and have the required redistribution of force for it to be wound healing. Now, difficult territory here is how long do you wear these casts? If you've got a neuropathic wound similar to the one I showed you in the picture with the forefoot relief, I would expect that, without any complications of infection, to be healed, watertight, in somewhere around 4 weeks, if the pressure is being removed from it correctly. What we do most often is we wait probably another 3 to 4 weeks before removing somebody from a cast once it's healed, to allow the wound area to become more vital. And by that, I mean, what you've got is you've got a fibrous piece, or a fairly fibrous piece of tissue that has granulated to heal, and you've got fairly elastic tissue on the other side of that. You need to allow for tissue integration. It usually is quite slow, but we found by experience, if we wait another month before we take somebody out of that cast, we generally speaking have a good chance of making sure that it doesn't break down further.
See the way that you would normally do a 4-layer slab.
Well, if you were wanting to reinforce the sole unit, or let's try and think of a scenario where there is dissension in the Lis franc area on the plantar surface. What you have is you don't have a flat surface to work with, you've got a step down.
Yeah.
So what you're doing is you're creating a bridge between here and here with the initial layer. Now it might be 4, it might be 6, it depends on the mass of the individual and it depends on the size of the bump. Because once you've got that laid over, you're using the turns of your bandage to bring that all in so that you've got a flat surface. Angulation wise as well, it's very difficult to wedge, or you shouldn't wedge the bottom of it with the material, because all that will happen is that you'll just take it from one area and add it onto another area. You've got to use the flat application as your baseline. What you certainly don't want to do is you don't want to wrap 20 layers round. One, it's very difficult to deal with in terms of its density, but you'll cook the patient's foot.
Yeah.
My good friend here will tell you what it's like inside. It does get quite warm. So you've got to be very careful. The most exposed area is this piece on the dorsum. So you have to do any of your external work using the material, because you've got the protection of not only the felt, but you've also got the protection of the first layer that's there. Having also said that, you've got to do it in a speedy fashion, because if you don't, then what you've got is you've got one set of cast going off before the other set goes off, and you end up with basically 3 bits of a cast which can fall together. So you've got to keep the momentum, and I suppose that's where both the hand skills and the experience of the application is quite important.
What do you use afterwards for them to walk in? A cast sandal?
We can use, depending on what we want to achieve, we can use a cast sandal, or we have trauma type shoe that's got a pitched sole and heel, just like an ordinary sole and heel. Because with all of these things, all offloading devices with ambulation, what you want to do is you want to promote protected ambulation. You don't want to make it too easy. Very often patients who have had an ulcer have been walking quite awkwardly, and when you apply the cast, it allows them to walk in a much more fluid fashion. But you have to put the restraining order on them to essentially, just take it easy. It's not designed, well, it's strong enough to do most things other than get wet.
These are larger than
You can see the cast sandal here. This is the type of thing that I was describing this morning that was used on that chap that had the heel lesion. Now, as you can see, it's rockered through the centre, and if you want protected ambulation where it goes through, so in this case that actually might not be too bad. But if you've got somebody that's got a mid-foot shackle with a foot that's dropped down there, then you don't want that. You would want something that's got a flat surface. So the type of shoe is dependent on what the wound is like. Now, I'm just going to get the plaster straw. There you go. So it's quite fetching. You'll be able to go out. I'll put another one on. You can go out Cinderella tonight.
Get lots of sympathy.
So, for those that are not experienced in doing this or using the saw, it vibrates, it oscillates. What you don't do is you don't push into it, you guide the saw and let the blade go through, okay? So it's not a chainsaw.
Go, are they?
Pardon?
They're not all having a go.
No, I'll do it for you. So, if you've not done it before, then what you do want to do is you want to get a marker pen and you want to mark your trim lines. Okay, so that you can follow it down. But it's most important that you don't bivalve the cast through a bony prominence. Okay? Right, best of luck. Right, you just see if you roll that back just a wee bit. That's it.
That'll lot like that.
Like the Matthews is curled up as it needs to be.
That's a big.
I think my granny's false teeth would cut better than that.
Maybe another blade. I'll put another blade.
You might need a steak knife, will you?
I'll ring you from New Zealand when I get back home.
Let's just keep it going
It doesn't hurt, just you can feel it vibrating. I'm trying to think if you're going to slip.
Relax.
I don't need on the toes, so.
So this is a total contact cast and a wound healing cast, is it?
It's a
synonymous?
wound
Same
healing
thing?
cast. It's not a total contact
Oh, right,
cast
okay, right.
because it's not in total contact with the foot. Total contact cast is where the material is in total contact with the foot.
Oh, okay.
You've seen Maureen from King's demonstrate.
Oh,
I
we've
think.
learned that as we go. Okay.
So you wouldn't be buying one of these, you would just remake it, would you?
You're half out. Right, just do your lift there, isn't it? Right. So it'd just be nice if I could get that wee back there. Maybe just put it down like just see if I can get one more bit.
Alistair here. What sort of thing is it? I can get a blade.
It's
maybe?
alright, I'm there I think. I've been just persevering.
Yeah, I
So.
can get one for Wednesday. Can I just see what type of blade it would be?
You just need a battery.
Sounds like that.
I'll get the rest of it. From here, across the intermediate cuneiform to there, so that it would give you free movement at the ankle. Okay? Just need to remember there's a leg attached to it.
Bivalve just means to cut it in
Cut it in
half.
two, yes.
Right.
Still on the outtakes, Williams.
You didn't get the compulsory expletive then. Bingo. So, back to make believe again. Bring that up for a wee second. We've cut the ankle out, we're left with this visor piece here. What would normally happen then is you use your EP strapping. So, back to where I was before. That would come across. Does everybody know what EP strapping is? Elastoplast strapping. That comes across. What you would do is you would check that there was no problem with flexion and extension in terms of the dorsum of the foot. The other small piece that I do here, if I can, is I would normally round the edges bearing in mind that wouldn't be there.
So you'd leave that on the foot, you wouldn't take the whole thing off?
No, that stays on the
That
foot.
stays on now?
That would be on the foot. That would be 48 hours, and we do a plaster and a wound check.
Plaster and a wound check for
The reason for that is, and maybe by the end of the year I will have changed my view on it, but we had no way up until fairly recently of checking the moisture that we'd actually put into and around the foot. One of our colleagues who's professor at the bioengineering unit in Strathclyde has a very nice monitor for wound moisture that we can utilise, and we've been doing some early preparatory work with this where we've actually inserted it into the cast, and I haven't tested all of the wool materials here, but certainly what we've found is that there's only a very small amount of moisture gets past the second layer of the materials that we currently use, so it doesn't seem to be a problem. If I take this piece off now, if you come and run your hand over the surface here, you'll see that there still is a dampness there. One of the challenges if you do bivalve it here and now is that this gets very kind of woolly, but I will show you. So 48 hours down, the visor comes off. What we then do is we get scissors. I usually use Lister bandage scissors for this, but I cut. I got a fright there, it was red.
You're not going to die.
Just change your nail varnish. Right, I'm just lifting that up. So, what we've done is going straight up the stockinette, going straight up, and if I just lift that out, you'll see there, I've got a relatively smooth, for the camera, relatively smooth inside edge. Now, what we would do before I took that off the foot was get sleek or the tape, and you tape the edges so that the edges are nice and defined. And as I say, normally after 48 hours it's not so woolly. And so you've got a nice defined edge there, a nice defined edge there. Trim off this. Now, this is the bit that a lot of district nurses in particular like. I think they must have served their apprenticeship stripping rabbits because they absolutely love to pull the guts out of these things. If you do that, it's dead, it's in the bin and you have to start again. So, the long and the short of it is keep the felt padding in the cast. Do what you need to do for your wound healing. Reapply a stockinette, if I may, just again, so the make-believe here is just bend that up for me. Always when you're applying even shoes or that is to keep the knee slightly bent and just apply. This foot's quite damp here, but stockinette's on that, apply that down there. You've got your two edges, they fold over and they tape, visor back on, EP strapping, and you're off and away. And it's as removable and reusable as it's safe. So what you need to do if you were taking it off to check it, you need to make sure that there's no indentations, that there's no bottoming out from exudate or dressing moisture. Make sure that there's no, check the feet. So for instance, that's just me going up and down there with the scissors. But the thing with it is just check and make sure that there's no problems with the foot. If it gets to the stage where you smell the person before you see them, then you know that you need to change it. But other than that, it's just perfectly ordinary common sense in terms of watching the foot.
So you cut it off.